Bandido.
The views and comments of the hosts and guests are not necessarily those of the station.
Hi, I'm Nicole Jacinto. Join us on Healthline with 𝗛𝗵𝗹𝗁 as we discuss the latest health and medical topics with doctors from 𝗛𝗵𝗁. For a healthier and uplifting lifestyle, tune into Healthline with 𝗛𝗵𝗁 on DZRJ 8:10 a.m. Radio Bandido TV. You've got questions, we've got answers.
Watch and listen to Healthline with 𝗛𝗵𝗁, Mondays, 5 p.m. to 6 p.m. Airing on Sky Cable Channel 224 and on all DTT boxes. Simulcasting online on Facebook and YouTube. Listen and watch on your mobile devices. Just search DZRJ Radio Bandido.
You're about to experience Healthline, a show where doctors from 𝗛𝗵𝗁 interact with you for a healthy, uplifting lifestyle. Moderated by Nicole Jacinto. You've got questions, we've got answers. So welcome to Healthline.
Hi, everybody, and welcome to Healthline with 𝗛𝗵𝗁. I'm your host, Nicole Jacinto, and today with us on the air, we have Dr. James O. Lam. Of course, he's a doctor from 𝗛𝗵𝗁. And today we're going to talk about prostate cancer, but we're going to focus more on the treatment. We did talk about prostate cancer a few weeks ago, but it's always good to know more and from different doctors. So today we're going to talk about a certain type of treatment for prostate cancer, but that'll come a little later. Dr. Lam, welcome to the show. How are you doing today?
Hi, Nicole. Yeah, thank you. Thank you for having me in this show. I'm doing
It's
well.
our pleasure. Thank you. Thank you for guesting on the show, for taking the time to share your knowledge and, and to help educate us about our bodies, our health, and especially for men, who are concerned about their prostates or who may be going through it, somebody who may be having a scare, or even the relatives or loved ones of men who are there to support them. So, as always, I hope the show gets out to the people who really need to hear it, who need to be aware. This is a platform to raise awareness. Always, sometimes like I talk too fast. Raise awareness about different health issues, different topics, and I understand today, like we say in the intro to the show, the latest health and medical topics, and one of the treatment that we're going to specifically talk about later is something that is one of the latest treatments indeed for prostate cancer. Okay, so doctor, could we just do like an overview of what? Let's talk about first, like, what is prostate cancer, and how is it diagnosed? First, let's talk about the prostate, like just very general, and what it does, and then what happens, like what exactly is prostate cancer?
Okay. So prostate cancer, it's a type of malignancy that's found in men, since men are the gender that have prostate glands.
Yes.
So it's a malignant transformation of the cells of the prostate that has the propensity to invade or extend to its vicinity or even spread to other parts of the body. So often these patients, they're diagnosed through biopsy. So initially they have symptoms, they seek consult with a urologist, they'll order imaging, and then if they see something on the imaging that's suspicious, they go for a biopsy, and that's how usually prostate cancer is diagnosed.
Okay. Yes, thank you, doctor. So, initially somebody may or may not have symptoms, but through an exam, or like if they have symptoms, they may go then through an exam. In the whole process that we talked about on other shows, they will see a urologist first, and they will be directed to a urologist, and then there are treatments from there on. And you're one of the doctors who does a special kind of treatment also. When it comes to prostate cancer. Okay, so doctor, who is at risk of having prostate cancer? Just to remind the people in the audience, is there a certain age group, a demographic, even when it comes to genetics? Yeah.
Yes. So So it's a cancer of men. So the common age for prostate cancer, or the risk where it increases, is about age 65 or above.
Mm-hmm.
There's also, it also depends on race. Usually, those of African descent or blacks, they have the highest risk for prostate cancer. Next is the whites, and then we have the Hispanics, and last in line is actually the Asians. But among Asians, actually, incidence of prostate cancer in Filipinos, I think we rank around second. I think, if I'm not mistaken.
Mm-hmm.
Other risk factors, they have also linked prostate cancer with obesity.
Mm-hmm.
And generally, it's the exposure to testosterone. So that's why for men, the risk increases as you age, because the longer you are exposed to testosterone, so your risk also increases.
Okay, that's a great way of saying it and explaining it, Doc. That's very, very educational and very key. The longer you live, of course, the more testosterone your body releases, and the more you're exposed to it inside your body, of course. Therefore, that's why the older you get, that's when the risk increases. That's great the way you put it, because I mean, it would just be like taking it for granted. Oh, because he got older, but that's actually the cause. I mean, that's the big risk there.
Yes,
Doctor,
but we shouldn't forget that a big factor is also genetics. So
yes.
if your grandfather has prostate cancer, then you're also at risk for having prostate cancer.
Yes. And you also find younger men who have prostate cancer, doctor? I mean, in general, or at least if you can speak through like the people you've met in your practice. Have you found that a lot of younger men are getting it as well at an earlier age?
Yes, some men do have prostate cancer at a younger age, but it's not very common. No? So we more commonly see it with the older age group.
Okay. Thank you, doctor. So it's more prevalent, or those of African descent have a higher chance of getting it, and then Caucasians, and then or white people, and then Asians actually have a lower risk. When you say Asian, doctor, do you mean like East Asia or Southeast Asia, or including Asian in general? Okay. And Filipinos, actually, we are the second. You were saying our numbers were Filipino men have the second highest rate
compared to our other Asian counterparts.
Okay. All right. Too much testosterone, huh? Okay, doctor. Okay. So, doctor, how do we know when you say prostate cancer is metastatic? Does that mean it's metastasized? And what does that term mean? Can you explain it to us?
So when you say metastasis, it means the cancer has spread distant away from the area where the original gland is. So for prostate cancer, the most common site for metastasis is actually the bone or the skeleton. Next would be your lymph nodes, and then third would be your liver. So commonly, these patients who have metastasis, the most common complaint is actually bone pain, since bone is the most common site for metastasis of cancer. So they would present with your doctor with back pain or bone pains, or in bone pains in general. And then when they do further investigation, find out that it's a lesion from your prostate gland.
Okay. Is it usually like in the lower back, or just any type of bone anywhere in the body? Like would it be an area nearer to where the prostate gland is?
Yes, more commonly it's nearer. So it's spread because it's from proximal and then to distant. So the more common sites are your lumbar area or your pelvic bones.
Yes. And as you said, also it can spread to your lymph nodes. And we have lymph nodes in the groin area.
Yes.
And does it often spread to like let's say our underarms, because there are lymph nodes there as well, or like our neck areas, or?
Yes, actually it has the propensity to metastasize even to distant parts, even if lymph nodes that are far from the prostate.
Mm-hmm. Okay, doctor. So when somebody what are the sorry, I my glasses are not like, I need to get my eyes checked. Dr. Edward Uy, calling Dr. Edward Uy. I'm gonna see you soon. Okay. Because I do have some notes here now. When how does somebody, apart from the pain that they feel, how does somebody usually tell that the cancer has spread? And how do you trace it, down to like what happens when someone comes in and says, I have these symptoms, and then they see a urologist, and then they see someone like yourself. Like, how do you trace it down to it started in your prostate?
So often you do imaging. One of the more common causes for metastasis to the bone, as I said, is the prostate. And so if you have metastatic bone disease, so one of the first things you think about is the prostate. So often this is the first thing you investigate. So your urologist could order an MRI, take a look at the prostate. If there's a suspicious lesion there, then that would warrant biopsy. So if it comes out that it's really prostate cancer, then most likely, then that's the origin of the metastasis. And then when you confirm this, the patient has prostate cancer, you do usually a battery of imaging tests to see how far along the metastasis has gone through. So you could do like a CT scan of the chest, a CT scan of the abdomen. You can also do a bone scan. It's a whole body bone scan where you can see if there's other parts of the skeleton that has lesions, or the more newer technology of what we call the PET-CT scan.
Yes, the PET-CT scan. Okay, so doctor, the first thing that would probably be ordered, I'm just like, please jump in and correct me anytime. I'm trying to recap what you said, to learn more. So to learn more for myself, usually it would be an MRI first, probably, and then you can also do a CT scan of the chest. But I'm interested in like getting a scan of the bones. What machine does that to see if it's spread to other parts of the areas in your body that have bones, which is like most of your body?
For bone scan specifically, we use a gamma camera, what we call now, or a single photon emission tomography scan. The difference for this scan with other usual radiologic imaging is that we render the patient radioactive. So the difference is, for example, you have a CT scan, it emits radiation, right, to image the patient. Whereas with bone scan, we give a radioactive pharmaceutical to the patient. It renders the skeleton radioactive, and then we use this machine to scan the skeleton. Take a look where in the parts of the skeleton the cancer has gone to.
And this is like it's like the radioactive material lights up or something. Then you tell them, okay.
Yes,
So,
exactly.
of course, you have all these machines in Makati Med, right?
Yes, correct.
But and to be very safe and to be really certain, if somebody, let's say if a patient walked in and said, I want to know how far it spread and where, like what is the one definitive like test that, are all of these tests necessary, or is there one that you can say, okay, for sure, if you take this scan, we can tell where it has gone to, like every little single part of your body?
Well, if you look at most recommendations and guidelines, they would actually order or recommend a battery of imaging. So your CT scan, your bone scan. But I would say if you want to go for a one-time imaging, I would recommend the PET-CT scan. PET-CT scan is a full body imaging. It analyzes from almost the entire body, from your base of your skull up to your thighs. And then it will show you specifically where these cancers have spread. And now for prostate, we have a new radiopharmaceutical that's specific for the prostate, and we can image this with your PET scan.
Okay, great, doctor. Maybe you can tell us about that. Like you have a new pharmaceutical that's specific for the prostate. How do you do that when you are still diagnosing the prostate cancer? Do you inject it in someone, and what machine do you use? And is it material that goes straight to the prostate, or do you have to wait for it to go through the entire body first?
Yeah, so we call it PSMA. It means prostate specific membrane antigen. So this type of radiopharmaceutical, it's quite specific to prostate cancer cells or the prostate in general. So what we do, we inject it intravenously. And then we give it time to circulate throughout the body. It's usually about 60 minutes, so about an hour. And after that, once it's circulated, it localizes to these areas of cancer cells, specifically for the prostate. And then we use a machine, what we call a PET CT scan. So it stands for positron emission tomography / CT scan, computed tomography. So it's a hybrid imaging. So we can use it to localize where the cancer has spread and how far the cancer has spread.
Is this the same type of is it comparable to technology where like let's say if some doctors will look at someone's brain, a neurologist, let's say, and they'll also inject like a radioactive material and then wait for it to kind of get to where the brain area is and also use a PET CT scan? Is that similar to that? Is that comparable in a way?
It has this similar technology, although the indication varies. No? So it's quite different. When you have, for example, a PET CT scan of the brain specifically, or an MRI of the brain, the indication is quite different. No? So these are usually for your dementia. You're looking for other causes of illness, no? But not commonly for cancer specifically.
Yes. So this new substance that you inject really looks for cancer, and in particular prostate cancer. Okay, so this is how long has this technology been around, by the way, doctor? This material that's fairly new, I guess in medical terms, fairly new. Or
well, it first started in Germany in 2015, but it arrived in our shores in Philippines around 2018. So it's been around for quite some time.
It's been around for quite some time. Okay. And you've had this technology for how long in Makati Med?
I think around several years already. Sorry, I can't recall exactly.
Yes.
We have it already for several years.
Well, that's pretty good considering like some very like top hospitals around the world like were just started like completely using what we're going to talk about after the commercial break, the exact treatment. 2022 kind of. So that's pretty good. That means that the hospital is very up to date with the latest, a number of the latest equipment that's used to treat not only particular kinds of cancer, but other things as well. Doctor, we just have to take a short break. And audience, we just have to take a short break. We'll be right back after this break. Don't go anywhere. Go ahead, use the bathroom or do whatever you want. Grab a cup of coffee, a glass of water. We'll be back with doctor here, and we'll discuss finally the treatment and how the process is in terms of treating metastasized or metastatic prostate cancer in this manner. And you can get that treatment in Makati Medical Center. So folks, stay tuned. We'll be right back.
You're listening to DZRJ 810 AM. We'll be right back after these reminders.
Hi, this is Dr. 𝗂𝗍 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable via Makati Med Mobile Care Access. As the name suggests, this service is mobile, which means that we go to where you are. Mobile Care Access deploys a team of professionals for face-to-face consultations and to conduct basic laboratory and diagnostic procedures, as well as vaccination and testing, depending on your needs. We can go to any location of your choice within the metro and readily offer these healthcare services to communities or groups. For added convenience, different modes of payment are available, including HMO benefits for those with a valid letter of authorization. We believe that access to affordable, quality, and compassionate healthcare is a basic human right, and we at Makati Med are doing our best to make this possible to more people. For inquiries, scheduling, or pre-registration, you may reach out to us at the following numbers. We look forward to coming to you and serving your community with Makati Med Mobile Care Access. Hi, this is Dr. 𝗂𝗍 and welcome to Makati Med Wellness Center. Located at Ayala North Exchange, the Makati Med Wellness Center is a warm and comfortable state-of-the-art lifestyle center where executive checkups and services that address holistic patient care and wellness can be done. We have a skin and laser hub, diagnostic imaging, health screening, mind and wellness care, and physical medicine and rehabilitation. The Wellness Center is equipped with modern facilities and staffed with competent healthcare professionals who are committed to deliver premium, personalized, and easy access healthcare services for both adult and pediatric patients alike. This is a great place to prioritize your health and well-being without having to be at the hospital setting. We are open from Monday to Saturday at 7 a.m. to 5 p.m. at the 7th floor of Ayala North Exchange, Tower 1 in Makati City. It is also accessible from the Makati Med Hospital through a bridgeway to Ayala North Exchange. For inquiries, you may reach us at these numbers. We look forward to serving you here at Makati Med Wellness Center. This is Dr. 𝗛𝗶𝘶 from Makati Medical Center, and I'm happy to share that our world-class quality healthcare with the heart is now more accessible and affordable at Makati Med Care Access, Araneta City. What's more, Makati Med Care Access is the only single-use hemodialysis center in Araneta City. It's now easier for patients to avail of renal care services right in the heart of 𝗂𝗏𝗏. We offer health screening and diagnostic procedures in this facility at affordable rates. You can get services such as mammogram, ultrasound, lab procedures, ECG, and many others. We believe that access to affordable, quality, and compassionate healthcare is a basic human right. And we at Makati Med Care Access Araneta City are doing our best to make this possible to more people. You can find us at the ground floor of Manhattan Plaza, Tower 1 in Araneta Center, 𝗂𝗏𝗏. We are open from Mondays to Saturdays from 7 a.m. to 5 p.m. and Sundays from 7 a.m. to 4 p.m. For inquiries, you may reach out to us at the numbers below. We look forward to serving you here at Makati Med Care Access, Araneta City.
You're back with Healthline, keeping you healthy, moderated by Nicole Jacinto.
Hey everybody, and welcome back to Healthline with Makati Med. I'm your host, Nicole Jacinto. We are here with Dr. Lam, and we're discussing prostate cancer and in particular how it's treated. And we'll get very specific later on with a certain kind of treatment that Dr. Lam is going to tell us all about. But before we get to that, doctor, can I ask you, okay, what happens if you don't treat prostate cancer in general, and especially if it's metastatic or prostate cancer? What can happen, like best case scenario to worst case scenario?
Okay, so in general, prostate cancer, if it's not yet metastatic, if you don't treat it and you just let it go, no, well, it will eventually spread. I mean, it can invade potentially the surrounding structures and then spread to other parts of the body. As I've said earlier, the bone, some organs, especially the liver, and then your nodes. Now, if left untreated, metastasis will eventually progress. So, for example, if you have metastasis of the nodes, it can enlarge It can impinge on other surrounding structures. It could cause compressive effects. It's in the liver. It could affect your liver function. And since it's most commonly in the bone, it could also potentially make the bone more fragile. So you're at risk for pathologic fractures. And of course, the pain. So bone pain is really quite painful. So if you left untreated, some patients would become debilitated, have problems walking, and in general they have problems taking care of themselves because of this pain.
Yes. Thank you, doctor. I wanted you to illustrate the whole thing in your words, because it's not just a matter of, oh, okay, just leave it alone, don't treat it. And then because some people say, oh, okay, sure, I'll just die in like whatever. But before during that period, you have some sort of people who will be, especially when they're a bit older, Anna, I just don't want to, let's just not bother. And unfortunately, there are also people who cannot get treatment because they cannot afford it, or they're not even properly diagnosed. But in between that time, there's a lot of pain that you're going to go through. Like I wanted it to come from you, the doctor, to say, if it impinges on a certain organ or nerves and the bone, then you start breaking your bones, or as you said, bones can break pathologically, meaning just for that reason, it weakens it, and then your liver, you can have problems. You'll be in a whole world of pain if you don't treat it, if it's already metastasized. I think that, I'd just like to emphasize that, so that people really get diagnosed and get checked and get treated for these things. And unfortunately, with the economic situation in our country, I just hope that, there are ways that our Department of Health and, our budget find a way to treat not only people with prostate cancer, but just find a way to help people with all kinds of cancer and different types of illnesses. But of course, there are doctors like you, who and for those who can go and get the checkups and everything else, they can go to you in your practice, in your hospital, and they can definitely get treated for it. Doctor, do you think also, are there steps to treatments before we talk about the particular treatment that we'll focus on today for today's topic that you're going to introduce to the public on Healthline with Makati Med for the first time when we in a discussion of prostate cancer?
Well, for treatment, it really depends on what stage the cancer is. So for early stage or very localized forms of cancer, it's usually treated with your surgery or with your radiation therapy. But if ever the patient comes in and it's already metastasized, and to give our audience a picture, about 10 to 20% of patients with prostate cancer already have metastasis upon diagnosis. And so if, for example, the patient already has metastasis, that means it's already a systemic disease, from localized, and now you have a systemic disease. So for a systemic disease, you have to treat it with a systemic form of treatment. So that's no longer surgery or radiotherapy, right? So the next step would be your hormonal therapy, because like we talked about earlier, it's influenced by your hormones, specifically your testosterone. So when you treat it first with hormonal therapy, what your goal is to essentially castrate the patient. So you want to withhold that supply of testosterone. So it could be done either medically, with drugs, either oral or by injection, or surgically. So you can surgically castrate patient, you remove the testicles, so you don't have any more supply of testosterone.
Okay. All right. And of course, when it's metastasized, that's necessary. I mean, castration, like in, old physical terms, you remove the testicles. Secondly, you can do it chemically, by giving medication, either oral or through injection. And I think that's also been used, that has been used for, well, actually, it's a different topic, but for like people who want to kill themselves because they're they're child molesters, or like they volunteer to do that. Not
Yes.
that prostate cancer relates to I'm just saying, like, that's been around for some
Yes.
time. And then, okay, so doctor, after those steps are taken, and like, okay, surgery and radiation, because when you talk about radiation, it's just that area, right? Like if it's contained in that area, you can take out the tumor or whatever it is, or maybe even the prostate gland if necessary, and you radiate that specific area. It's like going to it's like feeling like you get an X-ray every day for a certain period.
Mm.
So you give medication, and then um what exactly is we're going to talk about a specific treatment here, and I have to read it out because I'm really not familiar with it, so I'm looking so forward to you
Yes.
explaining it to me and educating me on it. It's lutetium-177 PSMA radio gland therapy. Okay. What exactly is that? And let's talk about the process, doctor.
Okay, so it's a very specialized form of treatment where we use radioactive pharmaceuticals to treat the prostate. What happens is sometimes, for example, your patient, like I said, they undergo hormonal therapy for metastasis, right? Sometimes they don't respond. So this is what we call castrate-resistant form of metastatic prostate cancer. And usually the next step would be chemotherapy. Now, this is a new treatment. So this is unlike chemotherapy, we're using radioactive drugs. So it's also systemic. You also give it through intravenously. But what happens is same concept with your PET CT scan. We use a radioactive molecule. We inject it, it circulates to the body, and then it localizes to your prostate cancer cells. No. So if you break down the term of the treatments, is lutetium-177 PSMA radioligand therapy. PSMA is what we see on prostate cancer cells. It's on the cell surface of your prostate cancer. It has receptors, and then we use a ligand. So this ligand acts like a homing missile, and it homes in on those receptors in the PSMA, which is commonly found in your prostate cancer cells. The thing with cancer, these receptors are overly expressed, up to 1,000 times more than your regular prostate. So the lutetium-177, this is a type of radioisotope that induces ionizing damage to your DNA. So what it does, it kills the prostate cancer. So what we do, we attach this lutetium-177 with the ligand, and then it attaches to the prostate cancer, and then it's internalized by your cancer cells. So what happens over time, this radiation that's very localized to that cancer will eventually destroy it. And what's good about this treatment is, as compared, for example, to your chemotherapy. Chemotherapy is also systemic, but it also induces some damage to your normal cells. That's why you have a lot of side effects, right?
Yes.
But with this form of treatment, since it's very localized to your prostate cancer cells, it has minimal collateral damage to your normal cells. So this is a very, very good form of treatment.
Yes, it is. It's not, I mean, as you said, the lye that you inject along with the lye meaning LYE, right? Okay. That you inject along with the lutetium-177, which I think it's an element you can find on the periodic table, right? It is.
Yes.
Okay, so yes, I wasn't that great at. I didn't memorize it. I could not for the life of me memorize it. And then when all the new elements came out, I was like, okay, never mind. So anyway, but it's I'm sure it's there. So that you said that the prostate cancer cells have receptors. So it's like the lies really it finds it, right? They target each other. It's like, I mean, it targets it. It's like it meant to be, they're attracted to it, and then they hang on to it, and then it treats them. I mean, therefore the lutetium-177 that's used in treating that, in killing the cancer cells radiologically, it's more effective really in finding all of the the cancer cells that are there in the prostate. And then, so okay, I have more questions about that. Do you how can you find the target, and do you usually use other equipment around it? Like, do you when you inject it, what does the patient go through like for treatment? Is it like them coming into the hospital for a certain period? Do they have to come in on certain days and get the injections? And do you use like any kind of imaging to also check on the target and see if it's working? Can you see it happening live? Live tuloy, but you know what I mean, doctor?
Correct, exactly. What we use first is the PET-CT scan, like I mentioned earlier. So it uses the same technology, your PSMA ligands. So we image the patient using the same radioactive ligand, so we can map out where in the body these prostate cancer cells have spread. So essentially, what we see is what we treat. So what we see on the PET scan, if it lights up, most likely this will also be targeted by your treatment. So same concept, we administer it intravenously. The patient comes in. We have the option of doing this as an outpatient basis or an inpatient basis. So it really depends on the status of your patient. If your patient is, say, has good functioning status, he can take care of himself, is ambulatory, is able to walk, then we can do it on an outpatient basis. Come in, get treated, go home. No? But of course, for some patients that who can't take care of themselves, who have lesser functioning, then these patients might be better to be admitted in the hospital.
Yes, and they may have other let's say compounding illnesses also that you might
Yes.
want to monitor, like maybe a heart thing or a lung thing or whatever it is. And how many sessions do you have to go through? Also, like, okay, if it's an outpatient type of thing, does the patient have to come back every day, or like for how long?
Okay. So it's usually, on average, it takes about 4 cycles to complete the treatment. But it depends on the response of the disease, response of the patient, if we were to complete that 4 cycles of treatment. So often we reevaluate the patient after every cycle and see if the patient is able to continue on to about 4 cycles. There are some patients who have no alternative treatments. They can extend these treatments up to 6 cycles. So it depends on the patient. Now, when they come in, usually the procedure itself is quite short. The actual infusion is about 5 minutes. If you include the preparation and everything else, probably less than 30 minutes or less than an hour. You're in and out of the procedure.
And like you're lying down or I assume you're lying down, and then the PET scan is a machine that's there, and then you're with the doctor.
Actually, no, it's not necessary for you to lie down. The patient can come in, sit down on a comfortable chair or a lazy boy. We infuse it, and then they can go home. There's no machine during the infusion, so we usually image them a day after.
A day after, okay.
Yeah.
So they have to come back the day after to get the image. And
Yes.
see, okay, this one lit up. This one's
Technically, it's like a
there,
2-day
okay.
procedure.
And two-day procedure, yeah. So I guess some would prefer to just stay if they're, if they don't want to go home.
If they're coming back.
Exactly, yeah. That would be one reason to stay. Also, like as you said, if they're not that able to take care of themselves, they might just be better off staying overnight, even if they're like, I don't want to pay for the room, but then the next day, oh, you're tired and you have to get the scan anyway. And also, doctor, I just have a question. Like, when you do the scanning with a PET CT scan, do you see the areas? I mean, does this just go to just to clarify, does the lutetium-177 just go to the prostate gland itself, or does it also go and attach itself to the cancer cells in the other parts of the body that have originated from the prostate?
Yes. So it localizes to every cancer cell in the body. So not just in your prostate. If your prostate cancer cells have spread, for example, to your bone, to your liver, it will also go there. It will home in on those cancer cells. It will attach and also potentially kill those cancer cells.
Thank you, doctor. Okay, so we're talking about cycles, no? You said it's usually 4 cycles. How far apart are these cycles?
It's usually about 6 to 8 weeks apart.
Okay. So a patient can come in and let's say they stay overnight, or for those who maybe need to be confined because of their weekend state, their weekend, not weekend state. How long do they usually stay if they're, let's say, weaker? Do you keep them an extra day just to make sure they're okay? So it's like a 3-day stay, or is a 2-day stay, enough?
It really depends on the patient. If the patient is well functioning and is able to care for himself, we can actually discharge the patient the following day.
Okay. All right. And then, so it's about 6 to 8 weeks in between the cycle. So once you've done the scanning after and said, aha, it's attached to this. Okay, then the patient will go home, and of course you've scheduled when the patient will be back for the next cycle. Let's say they've done the first cycle, it's the second cycle. Do you send them home with medication, with anything, or are they not? What can and can they not do while they're on this treatment?
Yes, that's a very good question. When you're going for this treatment, you have to make sure you're off chemotherapy, because some patients they're already under chemotherapy. So it's very important to educate these patients and their referring doctors that they must not have ongoing chemotherapy as well as radiotherapy that are targeted to your bone marrow. Now, the reason why we have this 6 to 8 week interval is to allow the bone marrow, allow the body to recover from the treatment. That's why we have this gap. And also during this time is when we reevaluate the patient. We can do a panel of blood tests, CBC, liver function, kidney function, making sure that the patient is able to recover from each session and is able to go on to proceed to the next one.
Okay, great, doctor. Let's talk about that. In between the 6 to 8 weeks, there is a time when the patient still has to come in for some evaluations, as you said, blood tests. So, like, do you take a spec 23 and like look at everything, or do you in particular do you look for? Let's say, is it tests that are associated, blood tests that are associated with the areas that you've seen that have been affected, or like just everything, like the works, like including their creatinine levels, their this, their that?
So it's more directed towards the condition of the patient. So we can do some blood tests to look for liver function, making sure your liver is well enough to go on to the next. Kidney function, because this treatment is primarily excreted to the urinary system. So we have to make sure your kidneys are functioning well. We have to make sure your blood tests are okay, your CBC, red blood cells, white blood cells, because one of the effects of this treatment is suppression of your bone marrow. So we have to make sure that these patients are well enough that when they go for the next procedure, there will be a slight decline in your blood cells. So we have to make sure your CBCs are okay before we proceed.
Okay. Yeah. So as you said, one of the side effects is that it affects the bone marrow's ability to create blood cells. So would that mean like the blood count would go down?
Transiently, yes. Yes. But it's usually temporarily.
The platelet count would go down? It could go down, the platelet count.
Yes, it could go down. But often it's transient, and that's why we have this 6 to 8 week intervals for your bone marrow to recover. Just enough time to recover for the next treatment.
And then you check on the red blood cells and the white blood cells and see that the red and the white wine are mixing well together. Just get ready.
Yes, and as well we check for the PSA, because this is one of the things we look at to see if your treatment is working. So your PSA should be going down if treatment is working.
Yes, the PSA is the test where it identifies that if the higher it is, then the more likely you are or you have prostate cancer. So it should be going down. And doctor, in between the 6 to 8 weeks, when do you usually conduct these tests? How much? Let's say, okay, the patient is gone for the first treatment, and then the next treatment is scheduled with 6 weeks or maybe 8 weeks, because you know it depends on the patient, and you feel that we need to
Hello, sorry. Hello.
at what point between the like there? I am here. I just
Oh,
cannot
sorry, you broke up for
see the
a
screen.
minute.
Yeah, I'll repeat my question. I just sort of can't find. Okay, here I am. I'm coming back on. Okay. Sorry, doctor. Okay. So I was asking, like in between the 6 to 8 weeks, when you conduct these tests to see if the patient can undergo the next cycle, like how many weeks would that be before you take the tests to see if the person can undergo the next cycle and if they've responded to the treatment?
We often do it at the 4th week after your last treatment. So, but it also, again, it depends on the patient. If these are patients that you have to closely monitor, we can do it earlier, sometimes at the 2nd week. But often, if the patient is good, in good function, we can do it on the 4th week. Then, if the results of that test are okay, then we can schedule for the next treatment.
So I have two questions here, doctor. Apart from not doing chemotherapy and stopping all of that, are there other activities that you tell the patient not to do in between the cycles?
Well, in terms of physical restrictions, not there. There aren't any necessary restrictions. So as long as the patient is able to function well on his own, he can do his regular activities as much as he wants, no? Or as much as he can tolerate.
So if the patient can still, let's say, for example, have sex and wants to have sex, do you tell them that's a good idea to do that? What if they take Viagra? I mean, I'm just asking like, questions that will pop up eventually. I'm sure some patients ask you, or like, can they drink? Can they go out? That kind of thing. Can they eat certain foods? Can they eat whatever they want? Or do you give them like also a sort of like plan, like in between, like you really shouldn't be doing this?
Diet, there's no dietary restrictions for activities. Well, for sexual contact for the older population, isn't a common problem. No? But if we do have patients that are younger, we just have to reiterate to them or educate them that you are actually radioactive when we give this treatment. So we advise these patients to reduce contact that may transfer bodily fluids because they may potentially transfer radioactive material as well.
Yeah.
Also, contraceptions. For example, if your patient is young and is still fertile, so we have to educate these patients that it's recommended that you do not father a child during this period of treatment because the radiation can affect the child.
Yes, your baby will come out radiated and be a mutant superhero. Okay. And then, okay, so thanks for answering that, doc. And then the second question I have is, what if you find that the patient cannot undergo let's say we're still on the first cycle, the second cycle, what happens then? Do you postpone it? How do you deal? You postpone it, okay.
Yes, we do postpone it. If we see that the patient's condition is not well enough to proceed to the next, we make sure first that the patient recovers, the body is well enough. So it's very important that when we do this treatment, it's a multidisciplinary approach. We have good communication with your urologist, with your medical oncologist, because it's a team effort. We have to make sure these patients are well enough to undergo this treatment.
And also, doctor, I mean, if they have other doctors like internists, cardiologists, you all work together as a team. And
Yes.
are there many patients you find that also like you recommend or who seek out psychiatric or psychological, help with dealing with the mental health issues that come with this kind of diagnosis and this kind of treatment?
Yes, of course. Mental health is very important. So if we see these patients, they have mental health issues, we refer them to a therapist or a psychiatrist.
Okay. So, doctor, let's say, okay, the patient has been, okay, so you postpone the treatment, and let's say up to the fourth cycle, and then you find out, okay, it's still there. Because you did mention earlier that it's 6 to 8 cycles. Why do some people need 8 cycles?
Okay.
Oh,
So
sorry, 4 to 6 cycles. Was it 4 to 6 or 6 to 8?
4 to 6, 4 to 6.
6. Okay, why do some people need 6 cycles and some people only need 4?
Okay. So often what happens is after the fourth cycle, which is the common average number of cycles, we refer them back to their urologist or their medical oncologist. And then if the disease has regressed, then these patients are potential candidates for active surveillance. So these are the patients you monitor throughout the rest of their lives. Now, for some patients, they may require another form of treatment, such as your second line chemotherapy. But for patients that cannot undergo alternative or other forms of treatment, but they have evidence that they were responding to the radioligand therapy, then this is an option to continue on with the radioligand therapy up to 6 cycles.
I imagine if they responded really well, then, and they didn't have any other options, you would be like, just go for it, 2 more cycles, and then you can, probably be okay. And doctor, for all of this treatment, are there any side effects, other side effects? Like we know with chemotherapy, people often vomit or lose hair. And are there any other types of side effects that people should know about, or, that they experience?
Well, one of the most common side effects, one is nausea. Some people feel like vomiting, but this is actually quite common a side effect, not just with this form of treatment, but
Yes,
with other forms of treatment, right? Another more specific side effect is inflammation of your salivary glands or your lacrimal glands, the tear where your
Okay.
tears are produced, because they also express these receptors where these ligands can also home into.
Okay.
So, but it's usually transient, it's usually mild, and it's controllable with other medications.
And when you say there that, is there like does it swell? Is it visible, or is it swells, or it's just uncomfortable for the patient? And what medication do you give to treat that side effect?
So it depends on the severity. Some patients would have tenderness underneath the jaw. Some patients actually tolerable, they won't feel anything. Some would experience decreased salivation.
Decreased?
Right. So they have dry mouth. But often these are well managed. So you can, for example, if you have decreased tear production, you can use those eye drops. You can drink plenty of water if you have dry mouth. So
Yeah.
these are very manageable. So if you have inflammation, you can use your over-the-counter anti-inflammatory.
Okay. So if you can use over-the-counter inflammatory. Do you ever give people like steroids just to treat the inflammation? And
If the inflammation is severe enough, yes, you may need steroids, but often these side effects are often mild.
okay. All right. So like, what if when you say over-the-counter, you mean like non-steroidal anti-inflammatory drugs? Okay. NSAID, yes. What if the person is allergic to NSAIDs? What do you give in place of that to reduce swelling?
Well, you
If
can, yeah.
problem.
Well, these are patients we can opt to give low dose steroids in case if they're allergic to NSAIDs. No?
Just
But like I said earlier, it's actually quite uncommon for you to have swelling.
okay. All right. Thank you, doctor. And then what is the turnaround time for the whole treatment? Like when do you monitor the patient for the rest of his life? Is there a period where he can relax and say it's done? Sorry, those are my had to do the yes. Somebody busted into the studio while doing the show. And those are my co-producers, my children. They're a bit furry. Okay, so anyway, doctor, as I was saying, like when you say that this is what's the turnaround time for all this treatment for them to actually feel better and be like, I'm okay now. I feel normal. Let us put ourselves in the presence of the show, children, and keep our silence. And then also what about monitoring afterwards? Is it for the rest of the patient's life or up to a certain period?
So often, since this is already metastatic, so this is already stage 4. So yes, it does require a lot of monitoring, and often it's for the rest of the life of the patient. And yes.
Sorry, I have a tough question. What's the survival rate? And based on using this, how long do patients usually live after? How many more years are they? I mean, does it ever return? Can it return despite using this treatment? If it returns, can you use this treatment again? I have to ask some difficult questions sometimes.
Yes, I understand. Well, there's no actual long-term studies that exist yet for how long it prolongs life, but there are studies comparing it to your first and second line chemotherapy, and what they found that this form of treatment has better overall survival compared to chemotherapy. It has longer progression-free survival. When I say progression-free, meaning the longer that the disease hasn't progressed, no? So, or stable. And it also studies also show they have better quality of life. In fact, patients, when they undergo this treatment, one of the things that they know, they have a significant improvement in pain, because you have bone mets, right? So it's very painful, and this is one of the things that highlights this treatment. There's improvement in quality of life.
Yes, the quality of life. I mean, yeah, if it's metastasized and it's all over in your bones, and bone pain is very painful, and any other kind of pain, I mean, that is something that, like, it frees the patient more of pain, so they do have a better quality of life. And sometimes, when you have less pain, you just suddenly get more energy to keep going, or somehow it works out that way. And you said there are no long-term studies on that, so okay, we'll leave it at that. But it's a very it seems to be a very, like, thing that, targeted type of treatment. And in apart from being targeted, it has all those benefits of, pain relief, and it's not as invasive. It's not really actually very invasive, but of course everybody suffers when they're sick. Doctor, I'm told we're running out of time. Do you have any final words or anything that you'd like to say about this type of treatment or prostate cancer or anything else? Or if you just like to say hello to someone?
So probably it's very important for our patients to to have an open communication with their medical oncologist and their urologist. Sometimes these forms of treatment, since it's new, not all people know about it. Not all people are aware of it. So it's very important to do your research, talk to your doctor. What are your options for treatment? What I say for this treatment, it's an option for those who don't have any other option. So it's a very, very good form of treatment.
Yes. It seems to be so, and I thank you, doctor, for being on the show and explaining this to us. And actually, I'd like to invite you to come back and talk about it even more, so that we, keep raising awareness. Hey, this treatment is available. First time I heard of it, I was like, okay, all right, this is going to be very interesting. And I learned a lot on this show. Thank you for educating me. And I'm sure the audience out there, keep watching the show, guys. Just keep repeating and watching it to learn more about it, because all the information comes from the doctor, and the doctor who has treated people with this type of treatment in Makati Medical Center, of course. Dr. Lam, thank you for being on the show. You're a great guest. And I do hope you come back and talk about this more, or any other topic actually that you'd like to, and the latest treatments. I mean, that's very good to discuss, so people know their options, and it's open. It's a more open forum, and as you said, ask your doctors about the latest treatments, and it's a team effort that you do anyway in your hospital. So thank you for being on the show. Do you want to say hi or bye to anyone before we go?
Yep. I'd just like to thank the team at our Makati Med Pet City Center. They really work hard, and it's through their effort that we're able to bring this type of treatment to the public and make it more accessible to our patients. So thank you to the team.
I'd like to thank them as well, on behalf of all the people who have been able to, not to benefit from their hard work. If you're saying they're working hard, I totally understand it. So many people get those in the medical profession who really do their job and go above and beyond, you really, really deserve some recognition and applause. Thank you for being on the show, Doctor. Do come back again. And folks will be back with Healthline with Makati Med. And so take care, everyone. And keep, if you didn't quite get it the first time, just keep watching, and even the old shows, and then you can sort of connect. Oh, we talked about prostate cancer and this one is a treatment. Doctor, thank you for being a guest on my show, and I do hope that you come back and talk about stuff soon. Take care, Doctor, and everybody, bye. See you guys. Take care.
Thank you for tuning in to Healthline with expert doctors from Makati Med, giving you the chance to interact, uplifting your lifestyle. Moderated by Nicole Jacinto. Tune in again next week for your weekly dose of Healthline.
The views and comments of the hosts and guests are not necessarily those of the